Okay. Hello to Live Pharma Coalition, that is LPC, audience, viewer, and LPC-73 Global Leadership Speaker, panelist, moderator. As you may know, every week Sunday at 11 a.m. ISD is the fixed time for the weekly LPC online pharma discussion. This LPC online pharma discussion sessions is for the all pharmaceutical, life sciences, and healthcare industry people from the all departments and sub-departments across the globe. Also, the LPC has started its commercial arm, that is LPC Mentor Program, for the LPC registered member to have a customized learning and sharing platform every month, third Sunday at 5 p.m. IST. So last Sunday, in a 2 month, we will be having the first and the second LPC Mentor Program, that is LPC 1 and 2 at the 5 p.m. IST. Kindly do the registration and be part to be fulfill your need of the customized learning and the skill which has been required in the pharmaceutical, life sciences, and healthcare industry. Third LPC Mentor Program will be on the this month, third Sunday, 19 September 2021 at 5 p.m. IST. Before we start the today's LPC 73 Global Leadership Sessions, I would like to share a past, current, and the future plan. This current number of the LPC, along with the aim, objective, mission, vision for the pharmaceutical, life sciences, and healthcare industry across the globe. And here, I will like to share my screen. Hope it will be rightly visible to all of you. The Live Pharma Coalition, in a short way, we called it as a LPC. Currently, the LPC is India's largest online pharma discussion platform. And from the day one, it is clear about the learning and sharing forum across the pharmaceutical industry. Why we call it as India's largest online pharma discussion platform, or how it's become the largest platform currently. As the journey began the last year, 2020 May month, with my college mates, seniors, and juniors of the pharmaceutical industry, and subsequently, along with me, the three joint executive members they have connected, Mr. Yashwant Mishra, Mr. Isis Verma, Mr. Vinod Vaswani, and this journey begins for the pharmaceutical learning and sharing across the globe. The LPC today, that what we are looking at it, it's becoming a large because of the every day, every week, every month, becoming the larger and larger, and reaches at the 70 plus pharmaceutical companies, 180 plus speakers that they're into a LPC WhatsApp group, and close to a 20,000 people reach onto a Facebook as well as YouTube. We got it for the all four session of the month, and by looking at the speakers and the audience area of interest, we did the bifurcation as per the week. 1 week is for the leadership team, where the all the sales and marketing leader they come and they share their experience. Week 2 is for the global, where the international marketing, all the global leader they comes and they share their experience with our the live audience. Week 3 is for the young, where the marketing people along with the product manager they come and they share their experience. Week 4 is for academic, for the students of the pharmacy as well as the MBA. Week 5 is for the women leadership, where the audience they get the different leadership pharma discussions for the different audience and the viewer. It happens every week. So not only the week bifurcations, but from the different respective departments, whether it's like the research and development, quality control, quality assurance, or international marketing, or the finance or the HRT, they comes and they share their own experience at that each point of time, what is the experience they have it. So to make this as a larger platform, not only with this number, but over the all the 30 executive, those who has joined for the each week, along with our the joint executives, they are like the taking this LPC onto a next level with the best industry or institution connect of weekly pharma live discussion. So today we are here for the second week. Second week is dedicatedly, it has been handled by our the LPC global executive teams, which has been like the sequentially followed with the Mr. Praveen Pandey, Mr. Hitesh Uprati, Mr. Saurabh Mishra, and Mr. Ashish Srivastava. These four people they takes care of the connecting the best of best people across the globe to our the live audience from the all countries. As I already said about this number, 20,000 is the Facebook and the YouTube reach. Currently, we have it 5,000 Facebook page people they get engaged. Those who watches the video onto Facebook and YouTube. 2,000 is the LPC YouTube subscriber. Currently, we have it. As mentioned about the LPC Mentor Program, so which will be on with a different topic for the customized learning and sharing for our the LPC registered member. And always we thanks to all our the live audience, those who was contributed on the larger side for the last episode of the LPC, that is Live Pharma Coalition 72 leadership team. Thank you so much. Those who watches is the live and subsequently those who has engaged as well as the seen that video in a week 1 week of the span. Thank you so much to the live audience. Coming to the LPC 73 global leadership, today's we have a very nice topic: South Africa gateway to Africa. So this is what the nice topic we have to. We have a discussions on this topic. We have a three renowned speaker from the South Africa, and as Hitesh sir he rightly mentioned about this is the first time all the three speakers they are from the South Africa and they will share their own experience. So along with the speaker, those who will be taking care of the today's session, so along with me, the panelist and the moderator, those who is connecting with us, or all are the LPC Global Week executive members. So starting with Hitesh sir, so I will hand over this session to Hitesh sir to be introduced or the all panelists, and subsequently along with the panelists or all three speaker. Over to you, Hitesh.
Thank you, Mr. Thank you very much. First of all, I will thank you again to start this noble cause called LPC Live Pharma Coalition. And today it is the 73rd Sunday when we are here every Sunday at 11 a.m. India time. Kudos to you, kudos to your effort, kudos to your passion. I really see that the hard work you have been doing behind the scene to keep the ball rolling and keep the the session getting better and better every day. So coming to the session, today we have a very special, very exciting topic: South Africa gateway to Africa. Africa is a market which is growing in double digits since last 20 years, since last 2 decades. And South Africa being one of the biggest market in Africa, a market which is having $3 billion USD dollar market. Okay, a different market compared to most of the African market because of the regulatory environment, because of the availability of the around 200 local manufacturing units. SAPRA being a very stringent authority. So any Tom, Dick and Harry can't go to South Africa and cannot start their operations there. And Africa per se, what is happening in Africa in last 10, 20 years, it is the fastest growing continent in the world. Okay, there are new regulatory agencies. There are as many as 54 regulatory agencies in Africa, which itself is a very Herculean task for the NMRA as well as for the industry. We are having the rapid urbanization, so the market is growing with a 2-digit growth. Healthcare infrastructure is getting better, and then the business environment is getting friendlier. So these are the attraction of Africa to most of the entrepreneurs, most of the countries, and as a professional to us also. So today we would be talking all these details with our great speakers from South Africa. As far as South Africa is concerned, we have two kind of companies in South Africa. One are the multinationals and other are the locals. In multinational, I believe Cipla, Sanofi and Novartis, they are among top 3. And in the local companies, we have Aspen and Ingram, which are the top companies. So the environment is very different because you have strong local company like we have in India, and you have strong multinationals, which is very different than any other African countries. As far as the disease file is concerned, ARV is the #1 disease there. Then comes other disease like malaria, TB, and communicable disease. And it is not only South Africa; it is all across Africa. The disease profile is almost same. As far as the growth is concerned, in Africa, we don't have any valid or any strong research agency, market research agency. So whatever I could gather, South Africa is growing at the rate of around 8% pharma market. But we have many other African countries which are growing at 2 digit, such as Botswana is growing at 12%, Kenya is going around 17%, Tanzania, where I am staying, it again growing at 12%, Egypt is going with 14%, and Nigeria is going with 13%. So Africa per se is a very, very attractive market for any pharmaceuticals company, whether in Africa or outside Africa. So this is about topic, and I'm sure today we are going to have a great discussion. We have speakers, Professor David, J.W. Bowyer, and Madam Kirti Narsai. Before that, I will introduce my co-panelists. We have Mr. Praveen Pandey, who has again the experience of Africa for around 10 years now. Then we have Mr. Ashish Srivastava, who also have the experience of Africa, though now he's focused more on the developed market. And we have Mr. Saurabh Srivastava, who has experience of Africa as well as most of the South Asian and Middle East Asian countries. With this, I hand over session to Mr. Praveen. But before that, I would also welcome to our all live viewers who have joined us with in Facebook as well as YouTube. Over to you, Mr. Praveen.
Thank you. Thank you, sir. It's my pleasure to be the part of African this discussion, because I have started my international career from African country only, and it has been from Kenya, then like Zambia. I had traveled in West Africa, Ghana also, and at present I am holding a position of Deputy General Manager for Gracure Pharmaceuticals Limited, and I'm looking after African market, Asian, Latin America, and CIS. Yes, I would like to share my 14 years experience on this LPC with, and I would like to learn also with well-known speakers. As much as possible, I would love to hear from you. We have multiple speakers today, so I would like to introduce Professor David Katrere, and it's honor for me to introduce him, because he has having a versatile experience. At present, he is working as a part-time director for University of Innovations, and he is full-time chairperson for organizing committee of Pharma Connect Africa. He has been a long time until present, almost 1 month experience from Tishwane University of Technology, where he is a professor. Is started. Then before, he was as a visiting scientist from different company, visiting scientist from Unina and Parexel as a chief bioanalyst. Professor has done PhD from University of Strathclyde. By education, again, Professor has done B Pharma and Bachelor in Pharmacy from University of Zimbabwe. This is a really good experience to listen so highly educated person on LPC, and most of our viewers would love to ask some online question also, doctor. So doctor, we will welcome you and LPC platform. From here, I would like to hand over session to Mr. Ashish, who would introduce himself as well as to another speaker. Thank you.
Thank you, Praveen. Good morning to my colleagues in India, and very, very early good morning to my friends in South Africa. It is my pleasure to, honor the esteemed guest line today, which happens to be very distinguished and have a very vast expertise and inherent knowledge. Probably not only the live audience today, but they will be these YouTubes are archived, and it could be a reference point. These presentations can be referenced anytime for the benefit of the people who are coming and watching the progressive audience, which I mean. Not taking much of a time, most of the guys you know me, but still just for the reference, I am having experience of more than 32 years, starting from the company like that, Servier, progressing from Servier to Cadila to Ranbaxy to Lupin, and lastly into Novartis. I was a global head institution where that was my last assignment as a professional, and thereafter I switched into consultancy mode. And for the last few years, I'm into consultancy and setting up plants in the United States, and also having a Latin American marketing assistance to marketing to many of the large pharmaceutical companies in premium Latin American markets. I would like to introduce uh, one of our distinguished guests, Dr. Kirti Narsai. So, pardon me because I'll be reading her profile rather than, it is better to be safe than sorry. So, and it is a little very distinguished. She has over 23 years of experience in the healthcare industry and has held several board positions on organizations like Johnson and Johnson, American Chamber of Commerce of South Africa, NEPAD Business Foundation, and others. She was also a member of African Regional Business Network of World Economic Forum for Africa, and has been recently appointed to one of the work streams on partnership for African vaccine manufacturing. She'll be responsible there for commitment to create local manufacturing capacity for vaccine production. And in today's times, it is very, very pertinent. We all know that. Kirti regularly speaks at conferences, so obviously this is just a left hand for her today, and webinars on healthcare and trade related topics, and has published several papers in international peer reviewed journals. She currently runs her own consultancy focusing on health and trade policies issues in Africa, while completing her PhD in pharmaceutical policy at Utrecht University, Holland. Uh, During her spare time, she volunteers as a mentor for African Academy of Sciences and Pan African Women in Health. Uh, prior to this, she served as a senior director, government affairs and policy at Johnson and Johnson, with the responsibility of sub-Saharan Africa, where she was responsible for leading this function in the region in the context of rapidly evolving health policy environment in support of company's core focus area, which are medical devices, pharmaceuticals, and consumer products. Welcome, Dr. Kirti, on board. And now I hand it over to our friend Saurabh to take it further. Thank you.
Thank you, Mr. Ashish. A warm welcome to all our viewers of LPC who have joined us from different time zones across the globe. My name is Saurabh Mishra, and I'm one of the executive member of the LPC Global Platform. Today, I'll be acting as a moderator for this good discussion. Coming to today's topic, South Africa, the gateway to Africa. To discuss the commercial aspects of South Africa, we have invited today Mr. J.W. Bauer, who brings along with him 20 years of work experience in sales and business development. Mr. Bauer has worked in different leadership capacities with a lot of pharmaceutical MNCs, particularly in the region of Sub-Sahara and South Africa. To name a few, he has worked as a country manager for Glenmark, as a vice president for Hetero Pharmaceuticals, as a vice president for Aurobindo Pharma. In his present capacity, he is serving as a director, Sub-Sahara and South Africa for Emcure Pharmaceuticals. Welcome, Mr. J.W. Bauer. Welcome to the discussion. Now, I would now like to hand over.
I would add something.
Please, sir.
Here. Mr. J.W. has moved from Emcure to FDC. Now he is heading FDC for Africa, for South Africa and Sub-Saharan Africa. And one thing which I would like to mention definitely for JW is an avid marathoner. And many people in India would not know that we have a marathon called Comrade Marathon, which is an 89-kilometer marathon, which starts from Durban to Pietermaritzburg. And he has done that marathon 17 times. So 17 times he have ran 89 kilometers. So welcome, JW. And in the meantime, would like to acknowledge the audience who are available from across globe. Right now, we have audience from many parts of Africa. We have Mr. Nimish Bhatnagar from Madagascar. We have Mr. Umesh Singh from Peru at 1 a.m. He is watching us from Peru at 1 a.m. Then we have Mr. Konstantin Magimba from Tanzania, Mr. Vipin Dikshit from Ethiopia. We have Mr. Robert Mugabe from Tanzania, who works for the Public Procurement Authority here. We have Mr. Isa Hango, who is the chairman of Pharmaceutical Society of Tanzania. We have Mr. Rahil Saad, we have Mr. Ashok VV. So welcome to all live audience.
We have Vietnam also.
To Mr. Praveen.
We have Vietnam also.
We are from Vietnam also. Yes.
Yeah.
Yes.
Okay. I'm taking from here. So we are going to initiate to listen from Professor Katrere first. So Professor David, we are inviting you once again to come on live and speak about African market. Thank you.
Thank you very much to LPC and to the organizers for inviting me. So I'm just trying to put this up. Right. So I'm David Katrere, as already introduced, and so I'm going to talk about the African regulatory landscape, but with a huge focus on South Africa as the gateway in the theme, and maybe explain why it's a gateway. So we kind of tend to think about Africa as a country, don't we? Whether we are on the continent, and mostly for those that are not on the continent. However, Africa is not homogeneous, so we are 1.3 billion citizens, and I always like to joke with my Indian friends and say, hey, if Africa was a country, it would be the second most populous country under China. So forget India for a minute. But actually, it's not a country. So it's 55 countries, it's over 2,000 languages, it's many, many cultures, indigenous and imported. And that's, in a sense, what makes Africa interesting and unique. When it comes to national medical regulatory agencies, we have 54 in quotes, because a lot of these are just a small office within the Department of Health or Ministry of Health in most, how they would term it in most countries. So actually, there are much fewer capacitated regulatory agencies. And in fact, WHO reports that 90% have minimal capacity. So most of them really have no full-time employees, adequate budgets, adequate oversights. And then you have 7% of those with low capacity, so a little higher. What it means is that 3% of these 54 are really set up as regulatory agencies according to the WHO benchmarking exercise. And 3 of these have level 3 maturity. So Ghana FDA and Tanzania FDA. South Africa SAPRA is trying to up its game. So the SAPRA is the only agency at the moment which also belongs to PICS. And it aligns itself with stringent or well-resourced regulatory agencies. So what's killing Africans? Because all of you are here to save lives through the products that you make. And this is something that goes back to a World Bank report in 2013. You can see here that injuries are big. We kind of avoid this, and yet there is potential for us to provide products in this area, whether they're intentional injuries, probably now even more because of the lockdowns and the frustrations and depression that comes with COVID-19. And then we have non-communicable diseases, of which I would like to highlight neuropsychiatric disorders. which again, when you talk about NCTs, we hardly talk about. We like to talk about cardiovascular cancer, respiratory. And that's because these are pretty big. And with COVID-19 now, these will, number one, get bigger, but number two, also cause more mortality and morbidity as a result. And then we have the normal culprits, HIV, tuberculosis, malaria. But what's also interesting is nutritional deficiencies, including so-called hidden hunger, and then respiratory infections. So this is what's making Africans sick. This is what is killing us. But let's focus then on South Africa and the Southern African region, which falls under a regional economic community called SADC. So SADC is 16 countries and 300 million citizens. It's, along with the East African region, has high burden of HIV and AIDS. South Africa in particular, injuries are a big problem. Snake bites in a lot of the sort of agricultural areas, hypertension, diabetes, cancer we've talked about. And then in terms of South Africa, here's South Africa. So you can see that it's got probably one of the longest shorelines in the world. And this is why we always talk about it as a gateway into the region. So you could, for instance, Durban is the busiest port in Africa. And for exports, a lot of minerals come out either through Durban ports or through ports around Cape Town. We are here, I'm here in Pretoria. So South Africa has 58 million citizens, as a per capita GDP of about $5,000. My colleague JW will get into a lot of these numbers. So let's take a closer look at South Africa. The epidemiology is slightly different, but take note here of non-natural causes of death, which account for 51,000 dead every year. And that includes anything from stab wounds to road traffic accidents. And I'll talk later about the one opportunity that, around wound and injuries that brings up. And then the usual culprits. So number one, tuberculosis, diabetes, cardiovascular, respiratory. This is pre-COVID and is probably still the same. So COVID, despite everything in the news being about COVID, is actually just a small blip. I think what it does do, it tends to accentuate diseases that people already have. Right? And then in terms of the pharma industry, so there are about 174. This is an interesting number because in South Africa, we capture everybody who's in the industry, apart from the pharmacies, as being manufacturing. So if you're a testing lab, you would be included in here. If you're importing products, you would be included here. And it's something that I have students, actually, we are taking a deep dive into this to try and see exactly who's doing what. Most of the products that are manufactured are generics, branded generics. More recently, we've started doing vaccines, at least the COVID vaccines. I mean, we've always done animal vaccines. And then we also do blood products. Number of distributors, 205, of which Imperial Health is probably the biggest, even globally. They now have, I think they're now in South America and Brazil. Through a partnership there, the number of pharmacies, just over 3,000, with over 13,000 active pharmacists and 27,500 prescribers. So these are doctors, specialists. We have over 500 hospitals, and SAPRA, which I will now get into, is set up by an Act of 2065, which has then been amended to set up SAPRA in 2015. Yeah, this figure is contentious, but it's around about there. Right, so this then is South Africa again. And what are the laws in South Africa? Okay, so we have a lot of laws, right? Medical schemes. So in terms of compensation or payment for products, the medical aids are very big here. They account for about 15 million of the 60 million population. So about a quarter of that. So products have to be on their lists. Then we have the Medicines and Related Substances Act, which is the main act governing registration of medicines, clinical trials, imports, labeling, and we will then get into that just now. And then we have the Pharmacy Act, and then we have the Professions Act. So health professions have their own acts. Then we have this one. I think this one has now actually been retracted, or there was an act like this, and then it was then collapsed into the amendment of this Medicines and Related Substances. And then we have the National Health Act. So if you're wanting to do any clinical trials, you have to think about that. Then we have regulations apart from the acts. And then we have the Traditional Health Practitioners Act. And then we have the Constitution. So you can see that it's a pretty crowded space legally, and can be quite litigious if you're not careful. That's why it's important to do the right things. And all of these are really aimed at protecting members of the public. So SAHPRA, which is the South African Health Products Regulatory Authority, came into effect 2 years ago now as a result of the amendment of that act. So when I say into effect, started, open their doors, as it were. Their core functions are clinical testing. So South Africa is a big destination for clinical trials. We've done over 2,500 clinical trials registered since 2005 when we started registering products, clinical trials. And it's actually very good to test products here because you're testing them in a very diverse population, ethnically speaking. Market authorization, so that's product registration, looks after GMP and pharmacovigilance. So just like any other sort of, I think there's any other core function of a regulator. What are they regulating? They're regulating pharma, and this includes vaccines and biological medicines, biotherapeutics. They also regulate radiation, actually. Probably one of the few regulators the only one in Africa, because we do radiopharmaceuticals is pretty big in South Africa because, as you know, we have uranium and other radio elements which are exported into the rest of Africa and I think other destinations. So this is a potential, for instance, to be able to get products out of South Africa into Indian markets, if those markets exist and are underserved. Complementary came in 2013, 2014. So we are actually probably one of the only regulators in the world to regulate complementary using a medicine regulatory framework rather than a food framework or the FDA's, not even the FDA, but the other act like in the US, because the FDA doesn't really get into it. Cannabis, medical cannabis is a new thing. Everybody's excited about that. Medical devices have now been brought in. So this is also new veterinary products. So I just want to talk briefly about market authorization because I think a lot of the audience would be interested in that. What you need is a local applicant. So it's not even an agent. The entity that is registering has to be a company that is registered in South Africa. And I think that's really for GMP compliance. So if a product has to be pulled off the market, you know that there's somebody that you can go to and knock on their door. Product registration, optimistically, we can put it at 36 months. So this is a pain point, and they are dealing with it within the regulator. So they have what's called a backlog project, which is trying to clear a backlog, a big backlog of, I think last time it was about 2,000 dossiers that had not gone through for various reasons. We have what's called dossier farming in this country, where people register the same molecule with 5 or 6 dossiers. So that can be problematic. And then we use the CTD format, which I'm sure you're familiar with. Then there's site inspection accompanying that before the product is registered, and has to prove that it's being made in a GMP facility. Import permits, so if the product is being made outside, then there's a whole regime of importing the product, import permits, post-import testing to look at integrity of the product once it has come, and then it is approved. Okay, just let me talk briefly about regional developments. There is a realization that even though Africa is many countries, for business purposes, we actually want to make it into one country. Huge task because of variable geometry, because some countries are more resourced than others. Logistics is a nightmare. However, there is that realization. So we are moving towards a lot of harmonization going on. The two most successful ones are the EAC, so in the Kenya, Tanzania, Uganda region, and Zazibona, probably one of the most successful stories around integration and harmonization around medicines. So Zazibona is 9 countries at the moment, 9 of the 16 SADC countries. And it does joint assessments and joint inspections. The whole idea behind Zazibona is to try and reduce timelines and also more better efficient use of resources. So products can go to Zazibona and be assessed there, and then they cascade down to the countries. So you still have, it's almost like double assessments, but the idea in future is that you break down the country assessment. So the country assessment will go very, very quickly, even though you still have to pay and submit in the specific country that you want. And now there's also the African Medicines Agency, which was ratified by 15 of the 55 countries in 2020, which means that it is now a legal entity. How it's going to actually work on the ground, we are not sure. But I think the thinking is that it will work through the regional communities, so through the Zazibonas, which will be very good. And then the other issues are pooled procurement. So this is something that they're talking about a lot in the SADC region for better pricing, better negotiating. And now increasingly we hear of the Africa CDC, which 18, 20 months ago, we didn't even know it existed. But now it's there, it's leading the fight around COVID. And earlier Hitesh talked about, one of the other colleagues was introducing Dr. Nasai and talking about this Pan-African Vaccine Manufacturing Initiative, which again is under the Africa CDC. So what have been the effects of Zazibona initiative? You can see here, since it started in 2014 and here in 2019, that in terms of timelines, the number of months for at least at Zazibona level, they've actually come down, right, to about 10 months. And then hopefully if it goes to the country and it takes another 6 months, I know of a product which took 6 months at the other country. So that's like 12 to 16 months for the product to be on the market. So that's great. As compared to the 36 months or 42 months. Right, so I'm going to finish by just maybe trying to flesh out a few opportunities or areas of focus that you might be interested in. So localization is very big as a result of COVID. I think it's big everywhere because people are now trying to cut down on these long supply chains, as it were, and trying to localize as much as possible. So there are now a lot of opportunities around manufacturing of finished product, yes, and that can be done, but also a lot of interest around API, which is a long shot, but rather start today. And then, of course, Africa is an agricultural country, and we know that pretty much all our excipients are from agriculture. So there's a lot happening in this space. In the university, I have a project where we're looking at getting starch from Bambara nuts. And that's really good because Bambara nuts are climate smart. They are hardy, so they don't get infected with mycotoxins like maize products. But that is at research level. The other sort of opportunity around localization is technology transfer. So tying up, India has an amazing history of innovation in this space. So trying to actually tie up with locals would be great. There are quite a lot of incentives floating around, especially in South Africa. And then product licensing and distribution. I think this has been kind of the traditional way of engaging. But let me caution that Africans don't want to be markets anymore. They want to be in the game. So whatever engagement you're thinking should really about initial product licensing, long-term in-country manufacturing. There's a regional value chain issue. I'm working actually for SADC right now on one of these, which is the antiretroviral regional value chain. So I'll be interested to know about companies that would be interested in getting into the ARV value chain on the continent, in the region, what they see as some of the opportunities and what they might see as some of the barriers. Along with that, there's also talk about innovations in pharmacy, so how can we get products to patients faster, more efficiently, safely? The Uber models, consulting online, that's actually an opportunity that's there because at the moment, there really isn't much going on there. And then in terms of therapeutic areas, I just wanted to highlight these ones. Biosimilars, there's a huge run on biosimilars, especially also in the COVID era. If you look at, there's a huge shortage right now of Actemra. And cancer is becoming a problem. Wounds, as I highlighted earlier, we like to have fun, we drive fast, we have big parties, and we end up with wounds. So wound healing is important. We did a study on HRT, right, hormone replacement therapies, and there is a shortage. It's actually dominated by one or two players here. I think Chinese. Ophthalmics, this I think is going to be an important area, especially given diabetes and where it's going, and even COVID has effects on that. The one thing that I left out is psychiatric medicines and maybe epilepsy. Epilepsy has always been a disease of the poor, neglected. Therapies are not very good. So we are finding that we are still using the phenobarbitons of this world, which make people very unfunctional. So I'm going to end there. At Pharma Connect Africa, we have a webinar series, so you can also look this up. It's on YouTube, and you can come through and meet with us at some point. But in the language of my people, I'm going to say Enkosi, Tatenda, thank you, Mazita, Zikomo Kwambiri. And stop there. Thank you.
Thank you, Professor. It was a very nice session. We have some queries also. But before moving to queries, I would like to summarize this session, which Professor David has just completed. There we come to know out of these 55 countries in African continent, South Africa is one where 58 million is population and GDP is roughly 5,000 up to data with 2020. The most affected disease has come as like tuberculosis, diabetes, and cerebrovascular, apart from non-communicable. Here we have found some companies who are manufacturing in South Africa. Aspen is one of them, Adcock Ingram. So I would like to share in that I was ex-employee for Aspen. Then we have come up to the market where Shapra is looking for multiple things. And as Professor said, 2,500 clinical testing is done in Africa alone. This is really a very, very big number. This is really a very big number. If we will go with marketing authorization part of SAPRA, so dossier it's coming in CTD format, common technical document, and average is taking 36 months to get approved. We have to finalize one local applicant also to proceed, and after that we can make a commercialization part from there. Regional development, which we have noticed one Zazibona. Zazibona, yes, I think it's coming in the eastern and southern part of Africa, where I think Zimbabwe, Botswana, Namibia also, I hope, comes, which we have noticed. But it was very active a few years back, and slowly it has been noticed it's going down in last 10 months. If we look about full procurement, yes, we have noticed like at present in South African market, negotiation is really on very high level. They have full information, and I'm the part of that. At present, we are negotiating with one of our clients, and the negotiation has started from 80% up to 35%. So high negotiation, this is true. Localization, which yes, it has been observed with multiple manufacturing companies, which they have initiated with IPI, API, even FPP also, which is there. And yes, doctor, this is really good information for marketeers as well as pharma companies also. Like there is big scope of HRT, biosimilars, and ophthalmic. I would like just to share my information, which I had got few days back. In the African market, Ghana is the one country where is the highest patient are there for glaucoma, and it has not been noticed for longer time. Now, many companies had initiated like glaucoma awareness function test and different type of. So this is really good information for South Africa, and thank you so much, Professor David. I will leave this session once again to Mr. I think if any question, Hitesh sir.
I will add few more things which Professor David had said. You know, there are two things happening in Africa. One is the integration. Zazibona is now even expanding to SADC. Okay, earlier it was Zambia, Zimbabwe, Botswana, and Namibia, and now they are trying to expand it to SADC. SADC is comprising of 16 countries, right from Tanzania up to South Africa. So it will take some time, and the similar kind of actions are being taken in EAC. So what African government politicians, they have understood that the market is big and they are not self-sufficient. So it is a good thought consensus from the leaders in Africa that Africa should be self-sufficient, and the countries are too many. We have population, but the issue is we have 54 countries. So if we will be integrated, then things will be easier. Both the things are going on for last 2 years. They have reached one stage in EAC. Now you can do the registration through EAC in all EAC countries, and the similar kind of initiatives are being taken in SADC also. So with the time, Africa would be an easier market to come in, number one. Number two, which is more important, which we don't understand sitting in India or sitting outside Africa, localization is the word. Because if we have a better local industry, things would be even stronger for the countries, in terms of the economy, in terms of the employment, in terms of the foreign exchange. So that is another initiative which each and every country is trying. So apart from just marketing authorization and selling our product, I'm seeing that we have a few entrepreneurs also from India. They can also think of putting their industry in Africa. Over to you, Mr. Praveen.
Right, sir. Thank you so much for this. At present, I would not like to take many questions, but yes, one gentleman, Mr. Ashish, he is willing to know about difference in Lesotho and South Africa, as they have different NMRA, or it has been handled by SAFRA only. Lesotho is part of South Africa. I think this gentleman is getting confused. Even say me too.
Yeah. Okay. Yeah. So Lesotho is the one country in the world apart from the Vatican, which is completely surrounded by another country. So it's a small nation surrounded by South Africa, and currently relies on South Africa. They do not have manufacturing, and but they also then rely on Zazibona, but mostly on SAFRA approvals. So they just generally accept products. That's why South Africa is the gateway. So you register your products in South Africa, you generally can then get them through to other regions or other countries.
Thank you so much, Professor. I hope Mr. Ashish is clear about Lesotho now. So from here, I would like to hand over again to Mr. Ashish Srivastava for further proceeding. Please.
Thank you, Praveen, and thank you, David, for our exhaustive and elaborate presentation. I hope we are.
Ashish, your voice is too low.
Too low. Yeah,
I hope this is better now.
Perfect.
Yeah, okay. So I just said thank you, Praveen, and thank you, David, for a very exhaustive and in-depth presentation. And I'm for sure that the audience is equally intrigued, and probably they will be having a lot of questions. And we have to have a little bit of patience before our two panelists complete their deliberations, and then probably we are free to take all the questions. Dr. Kirti, I invite you now to please take over the stage and enlighten the audience, please.
Kirti, you are muted, huh?
Yeah.
No, she's not.
Yeah. Okay, I'm just trying to share my screen here. Can you see my slide?
Not yet.
No?
You have, yeah, now, probably. Now we can, yeah.
Okay, great. All right, so thank you very much for this opportunity to speak to you this morning about the South African healthcare environment. So David has touched on quite a lot about the regulations and so on. I'm going to speak a little bit more broadly about the South African healthcare environment. It's constantly changing, and when you live and work here, it's really quite challenging to keep up with the changes literally on a daily basis. It's quite volatile. And but that's also what makes it quite exciting to work here, because as much as there are challenges, there's also as many opportunities. And one of the things that I think there's a couple of words that I can use to describe the South African healthcare environment. It's challenging, it's complex, you know, there's a lot of opportunities, but it's also quite an exciting environment to work in. So this morning, I'm going to be covering just a little bit about the overall structure and give you some statistics. I don't have a lot of slides. I'm going to just talk through some of the current changes so that you know what to expect. Because you're constantly looking at what the current state is, but also where the environment is moving to. So if you're doing business here, you constantly have to be thinking ahead of where the environment is moving towards, so that you can plan ahead. And right now, as we speak, there's a lot of deliberations in our parliament about the NHI bill. So what the NHI bill is our National Health Insurance Bill, and that is new legislation which the government is trying to implement, which is basically looking at trying to implement national health insurance, which is looking at universal health coverage. So it's a financing system which is trying to address the inequality that we have between the private healthcare system and the public healthcare system. So I'm going to be covering a little bit about that, and then also the African Continental Free Trade Agreement, which David did touch on a little bit and talk a little bit about regional value chains, local manufacturing, and then also share with you some of the work that we're doing on the Partnership for African Vaccine Manufacturing. So starting off with the South African healthcare system. This is just something that I've picked up, you know, in some of the presentations that are currently being presented in Parliament on the national health insurance. And here you can see what the split is between public sector medicines market versus the private sector medicines market. And you can see the differences between the figures here. So the public sector market, which I'm sure JW is going to be talking about in a lot more detail, considering that he's a commercial person. What I want to highlight here is the disparity between public and private sector. So the private sector only covers a population of about 9.8 million people. And that is the medical schemes population, which David was referring to earlier. So that's the private insurance market. And that market has been quite static for, I would say, more than 10, 15 years because of affordability. So, you know, insurance has become increasingly expensive for people to afford, and cover has not necessarily increased. And in the public sector, the spend has more or less been the same. And, you know, it's largely a tender market, but again, affordability has not really been addressed. So this is what the government is trying to fix, you know, this disparity or this inequality between the public and the private sector, because the public sector covers more than 45 million people versus the private sector, which only covers 9.8 million people. And you can see the differences between the spend between public and private sector. So hence, you know, the government trying to implement national health insurance. However, as a whole, the country cannot really afford national health insurance because we have a very low tax base. So if you look at our overall population figure, which David also presented, we're looking at around 58, 59 million people, but our tax base is around 16.8 million. And our tax rate per individual is very, very high. It's sitting at around 45% in terms of income tax. And then corporate tax rates are also pretty high already. So we already have an overburdened tax base. So affordability in terms of implementing this type of financing system is going to be quite challenging. Although there are other people that would say that we already have quite a significantly high spend overall if you look at GDP figures compared to other countries, but we don't necessarily have efficiencies in the healthcare system in terms of how we spend that money. And we don't necessarily have good health outcomes as to how we run the healthcare system in terms of human resources, in terms of capital infrastructure, et cetera, et cetera. So there's a lot of room for opportunity there to improve efficiencies. There have been other initiatives to look at how we can improve. So for instance, there's been an initiative to look at low-income medical insurance systems, but that has largely been a failure. There have also been other initiatives to look at efficiencies in the hospital system. So there have been audits done on the public sector in terms of hospitals. That has also not really reaped any rewards. And here I'm also showing you, for instance, another example of pathology services. So here again, this shows very much the same trend of public sector versus private sector. In terms of services, you see that the majority of services are coming from the public sector versus the private sector, but then you will find that the spend in the private sector is much higher. On the next slide, I'll show you, and this is looking at hospital beds. So you'll see that the overall number of beds has declined, even though the population has increased. But then, again, the spend in the private sector is much higher than in the public sector. We also have other issues that need to be addressed in terms of human resources. We have a severe shortage of healthcare professionals, for instance. So these are some of the challenges that we face. But at the same time, they do offer opportunities for investors to come in and assist in terms of addressing some of these challenges. And there are quite a few government incentives in place to attract investors, for instance, in terms of local manufacturing. And in terms of the National Health Insurance Bill, the answers are not there. And hence all the deliberations in Parliament right now. So there is room for negotiation in terms of what that national health insurance is going to look like, what that system is going to look like. And I, for instance, believe that there's still opportunity, for instance, to bring back the conversation around low-income medical insurance system to take the burden away from the public health system, because that is overburdened. So I think that's where I'm going to stop in terms of the South African system and move on to some of the discussions on the African Continental Free Trade Agreement. So, oh yes, I wanted to also just talk a little bit about, you know, some of the points to consider here. So, like I said, it's a two-tier system. And at the moment, in terms of pricing, so pricing on medicines in the private healthcare system, it's regulated by a single exit price, whereas the public sector has a tender system. If the National Health Insurance Bill does go through in its current form, the single exit price will be going across the board. This means that the premium price that companies get for their products in the private healthcare system will be eliminated. And you will get a lower price overall with a single purchaser system. This is not necessarily a good thing. You know, you will have an overall price reduction with potential increase in volumes. The other issues that need to be addressed in the National Health Insurance Bill are the governance structures, which are not clear. There's also a benefit package designs will potentially be problematic because of our disease burden. So, you know, there has to be a benefits package that is available at no cost at the point of care for every single person. And what that benefits package is going to look like is not clear at this point in time. And then the role of medical schemes, like I said, at this point in time, looks like it's going to be reduced to top up cover, but I still feel that there's an opportunity to bring back the conversation on low income medical schemes. Okay, moving on to the rest of the continent. We have now, you know, the ratification of the African Continental Free Trade Agreement. And this is going to create the largest free trade area in the world. And one of the things that I'm involved in is how do we create and optimize regional value chains, and particularly looking at the pharmaceutical sector. So I'm working with the Nelson Mandela School of Public Governance, and we're looking at how do we optimize the pharmaceutical value chain at a regional level. So at this point in time, like Hitesh was saying, localization is definitely top of mind for most policymakers on the continent. Every government official that you will come across in most African countries will want to have some sort of manufacturing footprint in their country. But this is really not realistic. And we have had, for the last 15, 20 years, we've had the Pharmaceutical Manufacturing Plan for Africa as an overall or overarching policy document on the continent. And most countries have some sort of manufacturing policy in the industrial policy, or otherwise they have some kind of manufacturing commitment that they're looking for in the national policy requirements. So for instance, Nigeria has got their 5+5 requirements. Ghana has also got some requirements now where they are looking for commitments from importers to have some sort of manufacturing footprint as part of your marketing authorization going forward. And, you know, this is not necessarily going to be realistic going forward. We need to be looking at this more holistically from a regional point of view, and then also from a continental point of view. And these are the kinds of conversations that are happening within the context of the Continental Free Trade Agreement, particularly looking at industrial policy objectives. And I think this has picked up momentum, especially within the context of the pandemic. I think this has been a huge wake-up call for the heads of state. And recently, the heads of state have gotten together looking at vaccine manufacturing. You know, this was a realization on how fragile our healthcare systems are, and that we don't necessarily have health security. And also, it has created an awareness of exactly how dependent we are on the external world for supply of pharmaceuticals as well as vaccines. And through that was born this Partnership for African Vaccine Manufacturing. The heads of state got together and they made a commitment that we would increase our capacity for vaccine manufacturing in the next 20 years to 60%. And different countries have been identified as hubs for this vaccine manufacturing. South Africa is one of them. Morocco is another, Senegal is another, Rwanda is another. And partnerships are now being created to increase this vaccine manufacturing. So this is happening under the leadership of the Africa CDC, and there are different work streams looking at different capabilities. So looking at, for instance, R&D, intellectual property and tech transfer. Myself, I'm involved in the market design and demand intelligence work stream. And in there, we are looking at what is the future vaccine market going to look like. So we are not only looking at COVID vaccines, we are looking at all vaccines, looking at how are we going to not only look at local capacity of vaccine manufacturing, but also looking at the procurement process. So David did touch on pool procurement, and pool procurement is definitely going to be the procurement process that will be adopted. And actually it has already started. So not so long ago, UNECA launched a pool procurement mechanism across 10 markets for maternal and child health products. And I think going forward, you're going to see that type of mechanism being implemented for more therapy areas across different countries. And that is really to address, you know, the negotiating power of smaller markets like Lesotho and Eswatini and others with these large procurement organizations and global multinational companies, etc. So this is a long commitment, and we really are at the very beginning stages of the work that needs to be done. The ambitions are quite high, looking at full and finish at the moment, but I do believe that we need to also fill the gap in terms of our R&D capabilities. At the moment, we lose 1 out of 3 scientists out of the African continent each year. And that is really not sustainable in terms of our overall R&D capabilities. I do believe that we need to invest more in R&D. African countries made a commitment many years ago to spend at least 1% of GDP on R&D. And at the moment, there are no countries that actually meet that requirement. South Africa is probably the only country that comes close to that percentage. We get to around 0.8% of GDP. And even then, we do also have an R&D tax incentive in South Africa. But even with all of those initiatives, we are not making the 1%. And I think that if we are going to be addressing public health challenges like this COVID pandemic going forward, then we need to be investing a lot more in our own R&D capabilities. And I think that's also another opportunity for foreign investors to get involved. We also have a long history of participating in clinical trials, and we're losing our edge in that area as well. So I think that there is another area for international cooperation and investment in clinical trials. So some areas I think that are opportunities for innovative partnerships with foreign investors are in the area of R&D capacity development. And I think India has done phenomenally well, especially now even in developing your own COVID vaccine. So there's probably opportunities for partnerships there. Then another area that I thought of was also in the area of logistics and supply chain. So we do have infrastructure and deficits, and you know, in areas like cold chain, road and rail infrastructure, etc. But we really can't wait for those types of infrastructure to be built. We need to look at innovative ways of transporting medicines, vaccines, and other things. So I think there's room for innovation in that area and partnerships also. And then also addressing the skills deficit. I think India does phenomenally well there, and we don't. So how can we partner in that area, especially in areas of manufacturing, in regulatory skills development, and other areas across the pharmaceutical value chain? And then lastly, in manufacturing. So I've spoken quite a bit about manufacturing. And one of the concerns that I've heard a lot of speakers talk about on other webinars that I've attended recently is, if we're going to invest so heavily in manufacturing, then what are the chances that these manufacturing facilities will become white elephants? How do we prevent that from happening? What are the new agile ways of manufacturing that we should be looking at that will prepare us for the future? And I think there are also ways and opportunities for us to partner with countries like India. So I think these are the areas that it would be great for us to explore. So thank you.
Thank you, Dr. Kirti, for a very insightful presentation. And actually, for me, it was a bit startling as well, because what we sitting outside from South Africa, the perceptions are, you know, drastically different of South African market, because we consider within Africa, West, East, North and South, and Southern being the most coveted ones, and the entry barriers, etc., which have been, you know, made us understand all the while. They have been given us the impression that, you know, it is one of the most developed, it is one of the most self-sustaining, and it is one of the most progressive pharmaceutical market. But your presentation tells a very different story. So it was personally for me, having spent so many years, it was a very, very, you know, insightful and enlightening, to be honest. I'll just take the audience, whatever you have said in a brief snapshot, that, you know, African continent free trade agreement promotes basically a regional value chain, local manufacturing, and partnership for value chain, etc. Personally, again, I was like, you know, again startled to see that the top three therapeutic areas are not tuberculosis or malarias of the typical African thing, but they are actually antidepressant, which is probably a sign of lifestyle, because South Africa is a little upmarket. Probably the GDP is a little higher. I'm talking about per capita here. So obviously these are related to lifestyle kind of a thing, and therefore when I see that it is antidepressants are in top three, I'm surprised. And then this anti-ulcerants are there. HIV, of course, we all know it has been a concern for Africa all the while. And then you gave an insight on how the public sector and the government sector works and the numbers which you say that, while the government has somewhere around turnover of 15 billion rands, and private is as expected again, it is around 46 billion, 45 billion, out of which a prescription alone is 29 billion. Number of molecules range up to 1020, and number of manufacturers are 178, which is quite substantial, I guess, considering the size and the population of the country. Then what was not pleasant to hear was that the hospital beds have declined over the period of time, and wherein the population, you said, has gone up by 25 to 50 million, which is doubled, but the number of beds have come down from 118,000 to 89,000, which probably has to be immediately attended to, I guess. And I think you, as you said, highlighted that you are acting, being a cog in the wheel, and instrumental in the government programs to see how this is can be taken care of. Then there was a proposal of two-tier system, which says that price is regulated by single exit pricing, and another part is the public tenders, which we all participate time to time. And there is a proposal on board, to consider a CP across the board, which means that you lose everything in that. And the interesting phase, which was the positive thing, is that AFCTA is now considering and will create a largest free trade environment probably, and that would be biggest in the world, which we understand, and that will help in combating the regional and local value chain, and it will probably come on a harmonious and more of a holistical platform, and they will be prioritized. And local manufacturing, as you say, though seems to be impractical, but since you have said it is on priority, and I also feel that local manufacturing has to be prioritized. And totally, I agree with you that not only South Africa, I would say entire Africa depends majorly on the imports of medicines rather than having it their own manufacturing base. But also probably it would be very interesting to know that there is one aspiration of getting into local manufacturing. At the same time, we have to see whether we have the local talent, we have the resources, and we have that kind of infrastructure to get into that mode, because that is a progressive step, and initiatives like you have been taking, these initiatives have to come very aggressively and very fast, actually, because then only 178 manufacturing plants are good, but it would have been very, very good if there are 400 or 500. So automatically the dependency would stagger down. Also, I would only like to add, it's my viewpoint, is that the regulatory spectrum, while David was saying that it is generally 3 years or so, but my experience is that it is not easy to crack one registration in less than 5 years. It goes up to 5 years. So while it sounds reasonable 3 years, but 5 years is like sometimes the molecule itself becomes redundant by that time. So these are the aspects probably which we can always look into, but very insightful, very, very in depth, and knowledge laden presentation. Thank you, Dr. Katrere, for that.
Yeah, so on that point, David did talk about the Harmonization Initiative. So within the context of the free trade agreement, they're also trying to speed up the implementation of the African Medicines Agency. So eventually they just want one African Medicines Agency. So you would have like one registration for the entire continent. But you can imagine like 55 countries, to get there, it's going to take a bit of time. So they're trying to do this at a regional level first. within the regional economic communities, like David was saying, Zazibona and the East African community, etc. So it's going to be a stepwise approach in terms of implementation, but that is definitely something that they're accelerating, because they realize that in order for local manufacturing to work and these regional value chains to work, that regulatory structure needs to work as well.
True, very true.
Yes, I totally agree with Kirti. You know, later on, sooner Africa will go on EU way. It may take 5-year, 10-year, or 20-year, where we will have the strong AMA, we will have a strong Zazibuna, or we will have a strong EAC, where you need only one registration for few countries, maybe for EAC, maybe for Zazibuna, or maybe for Africa through AMA. You know, just try to understand the practicality. 54 government, 55 government, they have to agree. Okay, first, the officials need to construct the strategy and policy. Then it has to get approval from all the parliament of these many countries. So it is a long process, but you know, the politicians, they understand that it is the need of ours for Africa to grow. This will happen. I have very strong feeling that it will happen. It may take time, but later on, sooner, Africa will have a easier market in terms of the registration, in terms of the entry. Because today, if I want to come to Africa from any outside country, you know, I will have a smaller market, a market of 50 million, 70 million, 30 million, 20 million population. So many of the bigger companies would never be interested, or they will never have focus. So if the integration happens, then only there will be a focus from the bigger company, and the market will flourish. There will be a better competition. You will have a better pricing for the consumer. It is going to happen. It is going to happen. It may take time. Kirti and Professor David, a lot of appreciation is coming from the audience. And I'm happy to share that today there are many stalwarts from Tanzania who are available in our webinar. David Masasi, who is the Chief Pharmacist of Government of Tanzania, he is there. He is appreciating you. Mr. Abbas Muhammad, who is the Secretary of Tanzania Association of Pharmaceutical Industry, he is appreciating Dr. David and Kirti's presentation. Then we have Professor Kale, who is the head. Might be Kirti and David would know Professor Kale, because he's also very active in all African associations or policy making. So he's the head of pharmacy department in Muhimbili National University, which is the #1 medical and pharma university in the country. And we have quite a few people from across world. I would say Mr. Ravin Jain is from Myanmar. Then we also have a big personality from India, Dr. Muhammad Shahbaz Alam, who runs a NGO called Pharma Ratan, and he is also trying a lot of things for the integration, for the business convenience between India and other countries, including Africa. So both the sessions are taken very positively, and there's a lot of appreciation to Kirti as well as Professor David. With this, over to Saurabh.
Thank you, Hitesh. Indeed, it was a very enlightening session on the regulatory landscape by Professor David and the policy framework from Ms. Kirti. It's now time to move on to discuss the commercial aspects of South Africa. May I invite Mr. J.W. Bauer to please share his experience with us. Mr. Bauer, the screen is for you.
Thank you, Saurabh, and my apologies about not updating my LinkedIn profile, because the last 2 months back I shifted to FTC. I'm going to do a short little presentation, and I'm going to focus on the private market, because I think some of the people that might listen in has got an interest in South Africa from a private market perspective. After that, I'll open it up for questions. So let me start by sharing this screen here. Is that visible to everybody?
Yes, it is.
Okay. So the topic really is the private market from a generic manufacturer's perspective. Now, there are a lot of perceptions about South Africa from a political point of view, from any point of view, but also from a pharmaceutical point of view. And I've been working with Indian manufacturers since 2005. And the biggest challenge is to often make people understand that the dynamics in our private market is very different to what people like it to be. I'm going to start off by saying South Africa, is this a branded generic market or not? Because the moment you're going to enter this country from a private point of view, you need to understand what you let yourself in for. I think this might not be very visible on screen, so I'm going to just enlarge a few things. So this was a McKinsey quarterly review done in 2007. And often strategic decisions are taken based on this sort of information that's out there. Now, the fact that this is 2007 is very important. So in short, you've got the y-axis here, talking about the likelihood of market escaping price intervention by payers. So how price sensitive is this market? And we'll have a look at where McKinsey has plotted the different countries in terms of this graph. On the left-hand side, you've got your price sensitivity axis, and then if you're going to look at this axis, the x-axis, this is the preference for brands, with obviously the left side being low and the right side being high. So the ability to create brands, and I'm going to talk specifically about the generic space. And if you see what McKinsey did at the time, and from an Indian perspective, they plotted India as possibly the most ideal pharma target in the world, being unlikely to be intervened from a pricing point of view, and a highly branded generic market. South Africa was plotted here, which indicated that the ability to create a brand is quite good in South Africa. But price intervention is there. So it's not from a pricing point of view such an easy market to enter. I'm going to quickly, in the next 5 minutes, debate if South Africa should be sitting there or if South Africa should be sitting there. In my opinion, the opportunity in terms of branding generics in this market is gone. And it happened for a couple of reasons, and it's important to understand that. So since 2005 in the generic space, DOH has brought out regulations and laws in an attempt to drive down pricing. That was in essence what they tried to achieve. Now, a couple of things happened, and I think some of my colleagues has shared this before. Single exit price came in 2005, which is pretty much a price control on the manufacturer's selling price. You cannot take ad hoc price increases. Once a year, you are given a price by government. Further to the SEP law, pharmacy and dispenser markup is also taxed. And there are further attempts to control margin in the value chain. If you talk about your logistic providers and stockists. So, more of these regulations are coming through to try and manage the margin in the value chain from a government point of view. So single exit price legislation is one of them by DOH. A very important change in law that also came through in 2005 is the ownership of pharmacy. Before, a pharmacist had to own a pharmacy. Since 2005, anybody can own a pharmacy, as long as you've got a responsible pharmacist. Now, that had a significant influence in terms of our pharmacy landscape, where your consumer will go and get his prescription filled. The classical community pharmacy that we've had in the past, that was a result of ownership by pharmacists, has changed a lot, and we'll touch on that. Very important, the third one, generic substitution is allowed at dispensing level. So a dispenser does not have to honor the brand on a prescription anymore. Any generic version of that product can be given to a patient once a patient walks in with a prescription. Makes a massive difference in terms of your approach if you enter the South African market. And then one worthwhile point to note is no discounting is allowed to any player in the value chain by the manufacturer or stockist or wholesaler. So all the perverse incentives, the attempt is to get rid of perverse incentives in terms of the value chain to drive brands. So in terms of this legislation, DOH has changed the landscape by a couple of laws in a big way from 2005. And hence my reasoning that the McKinsey report that had us as a relatively branded generic market is something of the past and has changed. Then outside of DOH, medical insurers also played their role since 2005. Because of these changes by government, they've also jumped onto the bandwagon. They brought out price referencing on generic molecules. So a medical insurer, which, and I think Curtis has referred to the private market addressing only the needs of 9 million people, or medical insurers addressing the need of 9 million people. Medical insurers now pricing in terms of certain molecules in the generic space. What they also do is they align with corporate pharmacy groups based on dispensing fee discounts. So a medical insurer can now send his patients certain pharmacies, certain doctors, certain hospitals. In South Africa, we call this preferred provider networks. So it has uneven the playing fields for a lot of pharmacies and a lot of dispensers since the laws changed, because corporate pharmacy obviously became a lot more significant, and I'll touch on that in the next slide or two. So if you're going to look at South Africa, you must realize that there's a shift in power from the prescriber to the dispenser. And if you're going to come into this market with the concept of a branded generic strategy, you know, you will struggle. And unfortunately, South Africa is very different to the rest of Africa, where the branded generic strategy is exactly what we do in those markets. We can still build brands where you have to debate that when it comes to the South Africa market. Now, if you look at the value chain, and I've got a very simple graph here, you've got the manufacturer, then basically in South Africa, we've got logistic providers. I think Kurt or Professor David has referred to that, spoke about Imperial here. You've got basically your stockist or your wholesaler, and then you've got your pharmacy and the retailer. That's the classic value chain. People that influence this value chain will be your insurers and will also be your prescribers. So community pharmacy is declining because of this ownership law change that happened back in 2005. Today, in private pharmacy, corporate pharmacy owns 65% plus of all pharmacy dispensing space. So your community pharmacy is on the decline. What corporate pharmacy has also done, and there's a lot of evidence now of this in South Africa, corporate pharmacy drive to vertical integrate into stockist, logistics, and manufacturing. The reason for that is because government is margin at certain levels, margin for the manufacturer, margin for your logistic provider and your stockist, and also your pharmacy. Corporate pharmacies become strong enough now to look at vertical integration back into logistics, back into wholesaling, back into manufacturing, which has made the branded generic model very difficult in South Africa, because your corporate pharmacy, your prescriber, the power is now being shifted to the dispenser. Stockist even, we see this in South Africa because even at the stockist level, margin is being controlled by government or tried to be controlled by government. Stockist even now to try to vertical integrate and even forward integrate into pharmacy or into manufacturing and logistics. So this branded generic model that we all strive for in Africa, in South Africa, has really become a price and a margin sensitive model, and not always necessarily the lowest price, but a price band that is allowed by your medical insurers, because a pharmacy would also prefer to sell a product that's in line with a medical insurer because he maximizes his margin there. Often less expensive products are not preferred because the margin is not maximized at a pharmacy and a dispensing level. And we can debate this. We can talk about this in a little bit more detail if there are questions around it. The reason for this is since margins are kept in the value chain, it makes sense to own as much of the value chain if you're going to be in the pharmaceutical industry. The price sensitivity is around the insurance segment, not necessarily the cheapest prices I've mentioned before, but the insurer's reference price, because this is where margin is maximized. So what you typically have found, and in my experience with a lot of the Indian manufacturers that I worked with, manufacturers in the last year has offered intellectual property, distribution rights, etc., to these value chain players to try and guarantee market share. So if you're classically going to be looking at IMS data today, you might see the likes of Cipla, Sun Pharma up there, Lupin as well. But a lot of the other manufacturers you might not notice in the South Africa market because the brands are not being done. It's not a branding generic space. They might have just as well given some IP to some local companies, to some local value chain players. So what you see is not always what you get. So there are some exceptions to these rules. Obviously, when it comes to new chemical entities, these rules do not apply to them. Branded opportunities are still there with new chemical entities. If you're lucky enough to be the first generic to market, and you've got some window of opportunity to promote it, you can still create a brand around this. Very seldom happens these days in South Africa that you get a first to market generic. You get all 15 of them at the same time. In certain generic molecule spaces where there are fewer generics, still possible to build some brands. Being a salesman and a brand builder, hence one of the reasons I've shifted to a company like FTC, which is in the ophthalmic space, and where there are fewer players in terms of the market, and one can still create some brands. And then obviously some of your sensitive chronic therapeutic areas. These switching of molecules at a generic level does not happen as often here, especially in the CNS space and onco space. So there are some exceptions to the rules, but if you're going to be looking at your general solid dose cardiovascular pain, even diabetes, a generic substitution is alive and well in South Africa, is controlled by the value chain. And if your strategy is going to be building brands in South Africa, you might find 5 years down the line that brand building is not the way to go. I'm going to end that there in short, and then very happy to entertain questions, because the private market is so vast and there are so many aspects and dynamics towards that I think in what I'd like to leave the audience with here is that think carefully about brand building in South Africa. If you're going to enter this market, you might end up losing a lot of money.
Thank you, Mr. Bauer. It was, though it was a very concise presentation, but a lot to comprehend actually. Very surprisingly, it has broken a lot of our stereotypes that South Africa is a branded generics market. You have presented a new perspective that yes, price sensitivity is going to drive the market. And the reason is because what we consider in traditional setup that it's the prescriber who leads the market. But here in South Africa, we are seeing that the shift is towards the dispenser and the insurer. After the 2005 regulations, there is a price capping, and also there's margin cappings in the value chain. So like what you said, the private players are trying to maximize their presence across the value chain so that they can capture the larger part of the value chain. So they are vertical integrations, both downward and forward integrations. We have also seen that yes, there are some exceptions to these rules as well. For example, the new chemical entities have some exceptions where they can be having higher prices as well as some brand values. We have also seen exceptions in terms of the first generics to market. If somebody is willing to offer a lower price product than the innovator. There is also some scope in the few generics market as well, where the market is not so much fragmented, and also in sensitive therapies such as onco. So it will be right to say that, yes, the prescriber and the insurer, the prescriber is not the king of the market right now. It's a dispenser and the insurer. And all the marketings and promotional activities now should be focused on these two players of the market. And that is the way forward for South Africa. Mr. Bauer, I have a question regarding the present perspective that we are facing, the COVID-19. What changes in terms of practices of sales and distribution and marketing have you seen during these last 2 years? What changes has it brought to the practices in South Africa? And what practices do you think that, what changes do you think that are going to continue? They will having a permanent effect?
Yeah, like the rest of Africa, access to hospitals has been restricted from a sales marketing point of view. A lot of us has adapted in terms of that. It's gone virtual. If you are a classical medical rep, your future might be unsure in this environment because, adding value becomes very difficult because you can't enter this. So those restrictions has also enabled some of the corporate pharmacy groups to sort of restrict presence of reps, not so much from a COVID perspective, but since, so one of our two biggest corporate pharmacy groups goes by the name of Dis-Chem and Clicks. These are both listed companies on our stock exchange. And if you were tomorrow walking with a Mylan azithromycin prescription, there might be 15 of these prescriptions out, 15 of these molecules in the generic space out in the market. The likelihood of finding that in any of these two pharmacies is small because they normally will have only 2 or 3 or 4 of the generics listed in their pharmacy, and that is it because they use the generic substitution law. So it was very difficult. So the COVID thing has now also empower these corporate groups to also say that we don't want to see reps anymore because of COVID regulations, because for them, the sales marketing people sometimes becomes a bit of an irritation because, people still try and influence people at a pharmacy level where, and a personal level where things are controlled, obviously from much higher up. So these accounts has become key accounts. So I think COVID has added to the need of these corporate pharmacies sort of to not have the classical salesperson in there anymore. They do appreciate if you send them people to help them, do stock counting and I'm trying to think of the word, organize your stock on the shelves and do the basic work. But the profile has changed a lot. That's on the one side from a COVID point of view. The other side that we've seen in South Africa is that people in specifically the flu space, antibiotics in terms of respiratory infections. We've gone through 2 winters now in COVID times, and these segments has significantly gone down from a value point of view, because of the lockdown measures that we have and people not mixing as freely. We've also seen a massive decline in terms of the flu season, as we know that. Typical flu products has done a lot less. Where on the other side of the coin, if you're a player in the immune space, and I think this is across the world, it's possibly not only South Africa, and we've certainly seen this in Africa as well, where people are in the complementary side of the business and the, zinc, vitamin C, these type of products has obviously become a lot more significant. So some of these companies that was under the radar before has become quite significant in the last 18 months because of their brands being in the complementary vitamin space. I'd say, from a private market perspective, that's pretty much the COVID effect.
One thing is for sure, for the medical reps, the times are not going to be easy for sure.
Yeah, sure,
Okay.
sure.
Over to you, Hitesh, sir. Please go ahead with the audience questions.
Okay. Thank you, sir. Thank you very much. Before few questions which are there in the chat box, I would like to acknowledge the viewers who are still with us after 2 hours of starting the program. Mr. Manoj Barthwal is there from Vietnam. Mr. Raghavendra Rao is from Hyderabad. Mr. Akshay Uprit is from India. And then we have Mr. Shivshankar Maurya, Mr. Arpan Kumar Paul, Mr. Ashish Gaur from Tanzania, Madam Chetna Patel, who runs a regulatory consultancy company in India. She is still online. Mr. Pankaj Srivastava, Mr. Arugman Arasan is there. From Nigeria, we have Santosh Patel. Then from Sri Lanka, we have Mr. Chanaka Ilangam Kara. Mr. Abid Hussain is there from DR Congo. Mr. Raveen Jain is still there from Myanmar. Then we have Mr. Bhaskar Chakravarti, who has been in Sudan for a long time. And he has highlighted that the map which Dr. David has shown, it has united Sudan. So next time, Dr. David, remember that unique map. Okay. Then Mr. Ajay Shah is there. Mr. Umesh Pratap Singh is still from Peru at 3 a.m. Peru time now. Mr. Constantine Magimba from Tanzania. Mr. Vipin Dikshit from Ethiopia. Mr. Isa Hango, who is the head of Pharmacist Association of Tanzania. He is appreciating the deliberation of JW, Kirti, as well as David. Mr. Rahil Shah, who is heading a pharma company from India, the international marketing, he is also heading. He's also appreciating you all. And JW, you have a friend there, the old friend, colleague of yours and mine, Karanveer Singh. Karanveer Singh is saying hi to you. Okay.
How are you doing, boss?
Karan has a question for Kirti. Karan is asking, Kirti, good to know that African countries are spending their time and effort in R&D in healthcare and vaccine production. Very insightful. As rightly pointed out, it's collaboration that can help African continent, and India being the most important partner since decades. It's a great idea to collaborate with industry. He had a question. Let me just take his question. I think. Yeah. He's saying, how is the AFTA applicable? It is for all countries or only SADC region? How convenient is it? Does it have flexibility in terms of registering each country in Africa, or any country registration is acceptable in South Africa and vice versa? Kirti, could you get the question?
I think so. So
Please.
Starting with R&D, we don't actually have enough R&D investment at the moment, and that's what I was referring to. So as much as countries have made a political commitment to spend 1% of GDP, in practice, they are not able to make that commitment. So there's an opportunity for foreign investment in the R&D space. I think we do need that commitment, and I think there's an opportunity for partnerships in the space, because if you look at our disease burden, and if you look at areas like neglected and tropical diseases and so on, those are quite particular to our continent and to some particular African countries and so on. So those innovations and those medical therapies are not going to come from the outside world. We need our local innovators to come up with those treatments locally. And so we need more research centers, we need more scientists in innovation centers on the continent. So I think there's a lot of opportunity for investment, for innovation on the continent. And there's opportunities for scientists from other areas of the world to come here and to create innovative partnerships in this space. So that's what I was referring to. So if we look at different African countries and look at the spend as a percent of GDP, then the percentages are quite low. Kenya comes close. I think they're at about 0.7, and like I was saying, South Africa is a little bit higher. Tanzania actually also does pretty well. I think you're about 0.68 or something like that. But other countries are very, very low. So that's essentially what I was referring to. And then when we look at infrastructure, it's also, we're lacking in the infrastructure, R&D infrastructure space as well. Then on the other question on the Continental Free Trade Agreement, it is for the entire continent. It's not only for the SADC region. And actually trading started already. Ghana was the first country to start with trade under the free trade agreement, I think in July, if I'm not mistaken. And the offices of the free trade area are based in Ghana. So Ghana is the host of the free trade area, but it is applicable for the entire continent.
Thank you, Kirti. Thank you very much. And the free trade area is not only for pharmaceutical, it is for all the commodity. So it is going to be a bigger this thing.
Yes, so it is for all commodities, but and there is a Secretary General who has been appointed, who is overseeing the ratification process as well as the implementation process. And his role is also to negotiate with all the heads of state in terms of the different laws, tariffs, etc., etc. And his office is based in Ghana. But they are prioritizing different sectors, that would, be basically looked at first before other sectors. And the pharmaceutical sector is one of those sectors.
Right. Thank you, Kirti. Thank you very much. We have a question from Dr. Divakar Jha. Dr. Divakar Jha is heading a pharmaceuticals company who are into supplements. So he's asking, supplement is one area which is growing in all continents. Some emphasis on supplement will help the audience. So maybe you or JW or Dr. David can take this question. Scenario of supplements in South Africa.
Okay, so that's, I'll take that. It goes to the complementary section of my presentation. So in South Africa, supplements are regulated by SAPRA through the Complementary Medicines Committee. So what we have actually is under complementary, we have what's called discipline-specific complementaries. So Ayurvedic medicines, traditional Chinese medicines, aromatherapy. And then we have a subsection which is health supplements. So we talk about those as health supplements. And it's easy enough because we actually have annexures. So if you go to the SAPRA website, there are annexures there. So if you're within a certain dose, you can make specific claims. And the idea is really just to have these supplements come in as more Schedule 0 and Schedule 1, which means that you can get them in a pharmacy or a food store. So they've really tried to make it easy. But if you don't mind, I just wanted to go back to the other issue. Obviously, this is a pharmaceutical audience, but I think one of the major impacts of COVID has been the disruption of medical tourism. And India has been the biggest beneficiary of medical tourists from Africa. So actually what that points to is trying to bring in, like Dr. Nasai was pointing out, the number of hospital beds have gone down. So there's actually an opportunity to have hospitals on the African continent, which are part Indian owned. A good example is Medwell, which is an Indian company, but now has an African footprint through South Africa. So they've gotten into a local partnership here, which I know quite well, and they run old age homes. But through that, you might then be able to put in pharmaceutical products like the pharmacies are doing. So you could build in a backward value chain. I just thought I would put it out there. Thank you.
Thank you, Dr. David. Thank you very much. Mr. Gagan Deepak, who runs a pharmaceuticals advertising and marketing agency, he's asking, isn't value chain integration happening in several other African countries too? Any of you can take this question.
I think the first indication of value chain integration happens where you see corporate pharmacy really coming to the fore. Now, I mean, if you places like Nigeria, you see small things, you see small initiatives like that happening. It's not there in a big way, but that's normally the first signs. Is if a pharmacy group gets together. And you know, I think Nigeria specifically, I'm aware of a couple of small chains, you know, call it 10 pharmacies at a time, and somebody from Nigeria can confirm this. I think in Kenya, these type of things are happening. It's very prominent in South Africa. I mean, you will find the Dis-Chem and the Clicks brand to use the two largest ones out there, and there are many more. So I'm not aware of Africa being this far down the evolution chain of value chain integration, like South Africa, but the first signs are there that because it starts with the pharmacy, the dispensing guys coming together because they can technically form a buying group, and the next thing that happens then is this integration into supply, which is the ultimate aim.
I just so to add on.
Very much.
Yeah. Sorry, I was just saying, so actually, I think the push is, even though we use the word localization, the push is really for regionalization. So from the SADC perspective, the idea is, at least from a manufacturing value chain, is what skill set do different countries have? And how can you then put them together so that you have a regional value chain? And that's quite daunting. Because as I said, you get in every region, you have these big giants which really want to have everything to themselves. But there are certainly other areas that one would be exploring. Like for instance, Swaziland is very big on sugar. So is it possible that sugar could be processed to a level where it then becomes usable in the manufacturing value chain of, say, antiretroviral? So those are some of the things that we would be exploring.
Yeah, thank you, Dr. David. In fact, integration is the key word for Africa going forward. Whether we talk of Zazibuna, we talk of SADC, we talk of EAC or AMA, it is going to happen, but it will take longer time. That is what my experience is. My understanding is, because I have been associated with the SADC, I have been associated with EAC. I was also into, Regional Pharmaceuticals Manufacturing Association of East Africa. So the government has a thought process. Government understands that it should happen, but the kind of process it will take its own sweet time. But Africa is going to that way when there would be one market, one agency, and lot of strength to the continent. Okay, Mr. Ajay Singh is making a comment. Hi, frankly speaking, things not look attractive because of 70% market, private market, but tiring registration process is killing the commercial aspect for any company. Okay, and then he's asking, and top of it, market shifting to dispenser versus prescriber. Just a question for Ms. Kirti. Has SAPRA started allowing registration of branded generic even in the absence of RLD and originator?
Yeah, so
okay.
registers all medicines.
Yeah.
Yeah, and David did talk about the backlog project. So they are trying to address the inefficiencies that they inherited from the previous regulatory authority. So, you know, the previous regulatory authority was outsourcing the review and evaluation process, which caused a lot of inefficiencies in the system. And so now with the new regulatory authority, they're bringing a lot of those functions in-house. And a lot of resources have been put in into the authority to address the inefficiencies and reduce the regulatory timelines. So I would say just be patient, and it is getting better. I don't know if David wants to add any more. Just one more thing that I want to add on before I hand over to David, and that was about this whole issue of the prescriber and the dispenser. It is true. I talked about, you know, the SCP regulations, and JW talked about that dispenser issue. So as much as we've got price regulations, which are in Section 22G of the Medicines Act, and that price regulation only applies to the private sector. So that is the price that you would submit to the Department of Health. That is your listed manufacturer exit price. You still have to then negotiate with the medical insurance company as to what your formulary price is. And generally, they're going to negotiate you down. And JW can correct me if I'm wrong. And that goes with new chemical entities as well. And with new chemical entities, you're also going to have to produce health economics, pharmacoeconomic data. And generally, you know, having worked for multinational companies my whole career, you're going to have to do that, prepare the dossier well in advance of the launch of your product and start having those conversations with the health insurance companies well before the launch, and negotiate with them before. So you would have to give them a heads up as to what your single exit price is going to be. But your reimbursed price is generally not going to be your single exit price. It's always going to be much lower than that. And we have some dominant players in the insurance market. And you would find that you're going to have to negotiate with them first. And whatever that price is that you've negotiated with them, all your other smaller insurance companies will follow. So, you know, that's basically how the market works, in my experience. JW can maybe add to that.
Yeah, let me have a comment just on the regulatory timelines. Somebody mentioned 5 years, and it's right. But, you know, in my experience, we've had products registered within 18 months, and we took also 10 years to register some products. I think the mistake that, especially from an Indian manufacturing point of view, we have made is that we look at South Africa as part of Africa from a regulatory point of view, and we almost expect the quality of dossier to be similar to a Kenya or a Nigeria. If you want to follow South Africa, you need to give European FDA standards. That's the bottom line. Otherwise, you will wait 5 years. 5 years. With SAPRA now, we've seen with recent applications that I was also involved in, that you can get products done as quickly as 18 months if your quality is good. There's also now the reliance pathways and these options that one can explore that can even bring product to market a lot sooner. So SAPRA is also, you know, in terms of certain disease entities, they're always going to favor, you know, ARV products, diabetes products, TB products. So, I mean, if you're going to add another paracetamol tramadol combination to the market, which is going to be the 20th one, you know, I think it makes sense. It might go into the sort of backlog or file 13. So one have to clearly think about, you know, what you file. I wanted to comment earlier also before I'll get to the pricing thing that Curtis just referred to. Somebody asked about complementary medicine or vitamins, etc. The tough part about that market, if you're going to be playing the classical vitamin B, vitamin C type products, you must realize that you're up against corporate pharmacy that produce these things themselves, that has their own labels. If you want to enter the sort of complementary natural space, you must make sure you've got some USPs around your product. Another probiotic with the normal culprits as strains, it'd be a struggle, because a pharmacy group, and these guys are very strong now, has got their own pharmaceutical manufacturing units, especially in the complementary space. So unless you've got something special, I think twice before I enter this market. Otherwise, it becomes just a low margin game, and you'd probably be disappointed at the end of the day. Then the pricing, Katie is right. You should think about, if you want to enter the corporate pharmacy space, if you want to enter listings with insurers, it's pretty much become almost a tender mindset, a tender business. If you can, the quality is generally there, because SAPRA, you would have a registration. If you have a registration in South Africa, the assumption is there that your quality of your product is good enough because it was registered. Then it becomes pricing, and because substitution is there, we are pretty much moved into a generic, into a tender space when it comes to large segments of the private market in South Africa. You need to realize also that there are certain boxes you need to tick. In South Africa, a very important thing which we've not touched based on is our Black Empowerment, BEE, Black Economic Empowerment, or called broad-based Black Economic Empowerment these days. Which is legislation that provides some deficiencies, or will try and bring some of previously disadvantaged people and companies into play. So you might have to look at partnering with certain companies in South Africa to get your BEE scoring right. At this stage, price is still king, but more and more certain companies get excluded from tender processes because they are not aligned with this Black Economic Empowerment. So there's a scoring system that you have to go through. It's part of your a commercial regulatory mindset that you have to have. In South Africa, we embrace that generally, but it's tough for people that comes from outside of South Africa and don't understand the history of our country. It seems unfair, but it is what it is, and it's got a place, and it's there for obviously the upliftment of certain societies that was disadvantaged in the past. Unfortunately, it's also been abused, as any of these things could be and can be. But these are the type of things that you have to keep in mind as well when you enter this market, is that you'll have to pay some dues towards the sins of our fathers to also be able to play in this game, sir.
Thank you, JW. Thank you very much. This is an experience which speaks volumes. You have nailed the point, I would say. Socioeconomic condition, every country is different. And when I'm coming as a marketeer or a businessman from outside, I need to understand the nitty-gritty of the country. Thank you very much, JW, once again. And we are already more than 2 hours and 15 minutes. So I would not like to take more questions now. Once again, thanks a lot to you, JW, Dr. David, Professor David, and Kirti. And I would request you to say thanks from your point, or any suggestion, anything from your point, starting from JW.
Well, thank you for the opportunity. This is still possibly the largest pharmaceutical market in South Africa. If you box smartly, you can carve out the space for yourself, but the mindset has to be right, and you have to change the rules somewhat when you come to this country. But otherwise, you know, it's still one of the most beautiful countries in Africa, and I've seen most of them. So it's looking forward to maybe see some new entrants coming to this country. From a FTC point of view, you know, we're always looking at licensing opportunities, etc. So if anybody else is out there and looking at the outsource model, I'm your man. You can connect with me, certainly. Thank you, Hitesh, for the opportunity.
Most welcome, JW. Most welcome. Kirti, over to you, madam.
Yes, Hitesh, thanks very much for the opportunity to participate today. I think it's an extremely exciting time in Africa. We're seeing so many opportunities and developments, especially with the Continental Free Trade Agreement. It's going to open up markets. So I think the future is really, really bright. And I hope that we will be seeing a lot more investment from all of you joining us today. It's been, you know, it's really challenging in a forum like this in 2 hours to cover so much because there's a lot to talk about. So please be in touch if you have any more questions.
Thank you, Kirti. Thank you very much. In the meantime, you know, some of our viewers are asking if we can share your contacts with them. To all of you three, Dr. David as well as JW. So if you permit me, I can share your contact with those viewers who are asking your contact so that there could be a win-win outcome with that. Or
Yes,
they may
absolutely.
know.
I'm happy
Thank you,
with that.
Kirti. Thank you very much for being here this morning from 7:30 a.m. on a Sunday. Over to David.
Thank you very much. And certainly you can share my contacts. I'm also on LinkedIn. So I guess we've got to think about building the cathedral, right? A lot of the European cathedrals, the people who started building those never worshipped in those cathedrals. So with anything, and particularly with Africa, we start building now and with partnerships. So the most important thing is, I think like JW rightly pointed out, nothing that is colonial or imperial will succeed, but things that are co-created by locals are more likely to succeed. So yeah, let's build those cathedrals, and maybe our children's children will then be able to worship in those cathedrals. And from the university side, we are always happy to to give advisory and to do whatever research that might need to be done, which we are able to do. So thank you very much for this opportunity.
Thank you very much, David. Thanks a lot. And viewers at Facebook and YouTube, I'm requesting you to subscribe, like, and comment on this particular episode. And if you have any other question, because we will have many viewers who will watch these at FB Live or YouTube later. If you have any question, anytime you can put on comment box. We generally try that our speakers would answer you, or we will answer your question, even if it is not today. Because generally we will have 10 to 20% viewer today, and maybe 1,000, 2,000, 5,000 customer viewers watch these program later through FB Live or YouTube. Thank you very much, everybody. And as usual, over to Mr. Raman for closing the session. Mr. Raman, welcome.
Yeah. Before I close, the take-home message from Saurav last.
Thank you, Raman sir. It was indeed a great insight, but there's a limitation of the program, right? What Ms. Kirti said, the 2 hours not enough to convey the message South Africa has for the world. Indeed, a great sessions. Thank you, speakers, and thank you, fellow panelists and moderators. Over to you, Raman sir.
Yeah. So now we have come to the end of today's live pharma coalition, that is LPC-73 Global Leadership Session, on a topic of very nice that we had today. Thanks for LPC Forum platform for giving me a start and the last part of word of thanks. Instead of saying thank, I would like to say all the best to speaker, because their journey is started on the LPC, that is Learning and Sharing Forum. Very nice, informative, useful, practical day-to-day experience sessions by our all three speakers. Very well time-bound, show run by all our the four panelists. And I would like to say all the best to our all live audience and the viewer. So Facebook audience and the viewer, keep liking and following the LPC Facebook page, and YouTube audience and the viewers, please do subscribe the LPC YouTube channel. Lastly, be a LPC Mentor Program registered member. So you can just text on to a number that is 9769681520 as a LPC registered member. So thank you so much. We'll close the today's session.
Thank you very much.